get through much on Tuesday, did we? Seemed like a lot. It was only like 3 slides. Jeez. Okay. We're gonna pick up. So in the notes, all these are up. I posted all the notes up on Blackboard, so you guys have them. I'm gonna do my best to do that after every class so that we keep up and we don't have to do like this giant note dump that I did last semester. You guys luckily didn't experience that. I'll do a better job. I didn't talk about this one. I would recommend you guys go through and actually watch this. This guy goes in and he talks about upper motor neurons, lower motor neurons, central pattern generators, and he actually explains it in a way that really is understandable. He spends about 6 minutes, and he did a better job explaining it in 6 minutes than I recall learning when I was sitting on that side of it. And again, putting a tilt on it to sports medicine and athletic training, when you guys hear upper motor neuron, what do you think? What are we conditioned to think as athletic trainers when it comes to upper motor neurons? Something like this, decorticate, decerebrate, whatever the rigidities are. I don't remember which is which. That's what we're conditioned to think the importance of upper motor neuron lesions, lower motor neuron lesions are. We think of them in regards to lesions. Did you guys talk about upper motor neurons, lower motor neurons at all, other than in that? Do you guys even remember that discussion? Okay. And he goes, so that's why I really think you need to watch this. He goes through, talks about it. I'm not going to talk about it too much in class. I'll refer back to it. We might expand on it a little bit later. We'll talk about it a lot. Central pattern generators, we think about that in regards to like breathing and automatic reflexes and responses to things. That's also our posture. So us just standing around, any of our postures that we get into, those come from our central pattern generators. Upper motor neuron, lower motor neurons, that gets into the whole neuroplasticity stuff we're talking about today. But definitely go in and watch this. Spend a little bit of time paying attention to what he has to say. Because like I said, I think it's like a 6, maybe 7 minute video. It's definitely worth the 6, 7 minutes to watch it. He can explain it way better than I can. If you have questions, ask. I'll tell you that it depends, and I'll watch the video and try to answer your question. Oh, I guess I was going to watch it anyway. We're not going. So this is where we left off on Tuesday, about making mistakes, making errors. I wanted to take just a second. We talked a little bit, very briefly, about top-down and bottoms-up. So top-down processing, bottoms-up processing. From a rehab standpoint, like I said, we need to be able to access both. We need to be able to know when to use both and when to correctly leverage both to create the adaptation to change the outcome that we want. In our world, as athletic trainers though, that we think we can out-exercise any situation, everything, I won't say everything, a majority of what we're taught and a majority of our focus is on the bottom up. Been teaching here 3 semesters, and I still don't realize that my laser pointer doesn't work up on that screen. We're taught the bottoms up approach. We're taught that if we can address a tissue, we can create a change. If we address scar tissue, we make change. If we address trigger points, we make change. If we improve blood flow, we make change. If we do this exercise, we make change. And that's not wrong. That's completely correct. We have to understand, we're accessing change through the sensations. We're creating changes in sensation. Last year, we were talking about mobility is important, tissue quality is important, not because of the local change that it creates, but because of the better sensory input that it creates. We want more range of motion to get more sensory input from the joint about what's going on. Not because more range of motion is good. More range of motion is good because it gives us more sensory input. Bottoms up, we're creating changes within the body, within the nervous system, and within our physiology through manipulating sensation. And remember, spend a little bit of time on Tuesday, starting to come to me now, talking about the 5 things the nervous system does. First thing is sensation. So what we're taught, all of our interventions focus on creating change through sensation. And it works. It just takes a little bit of time. Now, sensation was one thing. How many others were there? 4. I kind of give you guys the answer. Still around. There's 4 other things. All of our interventions, I won't say all, a vast majority of our interventions only focused on sensation, though. That's the only place the bottoms up approach addresses. That's the only avenue we have into changing the nervous system is through sensation. So what's one out of 5? That's like 20, 40, 60. That's like 20%. We're using 20% of our nervous system to create change, to create that neuroplastic change, which means we're neglecting 80%. Top down, recognize the other 4 things the nervous system does: actions, behaviors, thoughts, emotions, feelings, and perceptions. So top-down processing, the top-down approach to change, we're now utilizing the other 80% of what the nervous system does. There's neither one is 100% the only way to do things. There are times where we have to initiate that change through the tissues. We often run into that following an injury. If there's swelling, if there's a fusion, if there's a wound, a surgical incision, if they have a new tissue, an ACL reconstruction, they have a graft in there. If they have a reconstructed tissue and a Achilles repair, we have to create change and sensation to the nervous system by addressing that tissue. If there's trigger points, but here's the thing, we feel the trigger point wherever it is locally, right? We get so used to, oh, trigger point right there. Well, we have to understand the trigger point that we feel, this is just a physical representation of the trigger point, and that trigger point doesn't exist here. The trigger point exists on the cortex. And so when we address this, when we address the trigger point, the tight band of muscle, or whatever it is we believe this is, or whatever it is the different authors describe this trigger point as, whatever this is, we have to understand that we're leveraging this tissue to create change on the cortex. And that's why we get an improvement in sensations, which then gives us the window of opportunity to initiate neuroplastic change. Does that make sense, kind of? So top down has its time and its place. We have to do it. Bottoms up has its time and its place. We have to do it. When things really start to come together is when you can recognize when the right time for each one is and make that change on the fly and create what you need to create out of what you have access to. Again, the exercise is the least important part of what we're talking about. We can use exercise to manipulate top-down learning by having them pay attention to what they're doing, by manipulating their perception of the situation, by getting into their thoughts, their emotions, their feelings with it. We can also use that exact same exercise to manipulate what they're feeling as part of sensory input, their sensations. So we can use a deadlift. And the deadlift can be either something that we manipulate from a bottoms-up approach or the top-down approach. So it all comes back to what our intent is with that intervention that we're utilizing. Majority of our manual stuff, majority of our hands-on stuff, and majority of the stuff that we actually do to address tissue quality, we're coming at it from a bottoms-up approach. But once we get into the postures and the patterns and the shapes and the exercises, then which approach we're taking is very heavily dictated by what our intent is. So again, the exercise is really irrelevant when it comes to this stuff. If we're doing cupping, which one of these are we leveraging when it comes to cupping? Bottoms up. If we're doing an exercise to focus on the soleus, not the gastroc, we're doing these fancy half-kneeling heel raises. And I'm having them really pay attention to what they're feeling in that calf. And they're sitting here just like this, an expert at this exercise. I practice this. Does it look like I'm having trouble hanging out here? No. Does this look pretty easy to me? Am I leveraging top down or bottom up? Still bottom up. Now, if I get down here and I'm really wobbly, when I'm just struggling to get here, and this is a much slower movement, and you can tell that, my focus is right here, because if I'm up here, I'm falling down, and I'm really having to pay attention. That bottoms up or top down? Top down, because this is a very serious situation for my nervous system right now. My perception of this, my thoughts and my actions are all on me not falling over right now. The emotional side of it too, because I don't want to be embarrassed. I just fell over in front of all of you guys. So again, we can leverage what we need to based off of the intent that we're trying to get after. We talked about errors. We talked about the importance of error. Oh, I forgot there's a whole nother section on there. I just put this together this morning, so I'll figure it out eventually. Why this matters, because that's also important. When we leverage changes to the tissues, if we have tissue atrophy, we have an atrophied tissue, and we start working today to address that tissue atrophy, and we measure the circumference of the muscle, we measure the circumference of that muscle belly, how long is it going to take before we actually see that atrophy start to go away? We measure every day. When are we actually going to see that measure of 36 centimeters increase to 37, 38 centimeters? If we're coming in and we're doing things 3 times a week, we have the variables that we need to address to get into the hypertrophy range, we have all that taken care of. How long is it going to take before we see that atrophy go away, start to go away? 6 weeks. Long time. Depending on the degree of atrophy, depending on the muscle we're talking about, we might not see any change for 6 weeks. We might start to see a small change at about the 2-week mark. Now, that's a big window, 2 to 6 weeks. Yeah, it is. But if somebody's been in a walking boot for 8 weeks and their gastroc has pretty much, they now have an anterior tibial plateau, and we can visualize their posterior tibial plateau because their gastroc is non-existent, we're going to see change. We're going to notice that change quicker. So you're not going to see it before 2 weeks, though. And the reality is, for most of the people that we're dealing with, it's going to be in about that 6-week range before we start to see any change. So we're going to see change, but it's going to take a while. When we start dealing with scar tissue, how long does it, remember when we talked about the collagen 3, it gets all laid down in all these haphazard ways, and the whole reason that we're doing the manual stuff is to get the realignment. How long until we start seeing changes to the scar tissue? We're doing the stuff 2 to 3 times a week. We're spending adequate time on it. Our skill set's there. How long before we start to see that change? You can start to see change in 7 to 10 days. If your skill set's there, if you're doing the right things, if you're exposing them enough to that stimuli, then you will see the change. If you don't see it in 7 to 10 days, then you have to ask yourself, am I doing the right things? Am I doing the right things correctly? And am I getting enough dosage with this? Because you can be doing all the right things, but if you're only working on scar tissue once a week, that's just not enough time. It's not enough stimulus to the collagen. But it's still going to be 7 to 10 days. When we leverage the bottom up, it's going to take a little bit of time before we see any appreciable differences. When we talk top down, and when we start talking changes to the nervous system, we can have a significant change tomorrow. If we're doing the correct things. If we leverage what we're going to finish talking about today in regards to neuroplasticity, if we leverage neuroplasticity correctly, top down, we can see significant changes tomorrow. Now, will those be will tomorrow, will the thing that we were trying to fix, will it be completely fixed tomorrow? Probably not. But it will be noticeably better tomorrow. Whereas with our tissue quality, if we're going after, let's just use something that's very common for us to target in the athletic training world, dorsiflexion. I used it over at Forsyth, angle board daily. I hate to think how many hours I stood on the angle board over there. Guess how much my range of motion would increase? It would increase quite a bit when I was done with the angle board. I'm like, oh, look, dorsiflexion. And literally 5 minutes later, I'm like, yeah, remember what it used to be like? I don't have it anymore. Lost it. Trying to change tissue. Changing tissue takes time. Changes in the nervous system, we can start to see that change tomorrow. Which, remember back to what we talked about last week a little bit, one of the first questions for the class. Where do we first see the body experience loaded dorsiflexion? Quadruped. We make changes to the nervous system in regards to dorsiflexion beginning in quadruped. Now, can you think your way into more dorsiflexion? If we could, I wouldn't still have my mortal enemy of dorsiflexion that follows me around all the time. Can't just think our way into it. We will have to do tissue work. And if you do tissue work, you will see dorsiflexion improve in 7 to 10 days, and you'll see it stick in 2 to 6 weeks. A long time. If we then, we've made the tissue quality change, we've improved sensation, we've come at it from a bottom-up standpoint, and then on top of that, we now layer in top-down, and we introduce that new range of motion to the nervous system through quadruped and progress from quadruped up into half kneeling up into standing. Now we've leveraged both the bottoms-up approach and the top-down approach. Especially if we leverage when we're getting into that quadruped, half kneeling and standing, especially if we leverage step 2 and step 3 that we're going to talk about today. Then we can actually see that 2 to 6 week time frame rapidly decrease. Then we can build on top of those tissue changes with actual neurologic changes. Talked about this one, step 1. Got to make mistakes. Got to have errors. Errors are what send that signal to the brain. That's something that go the way that we wanted. That feeling of frustration that you get is epinephrine. We've heard of epinephrine, right? Have you guys heard of norepinephrine? Have you heard of adrenaline? Has anybody ever told you those 3 things are all exactly the same thing? Adrenaline, epinephrine, norepinephrine are all exactly the same thing. Norepinephrine is adrenaline that's released within the brain. Epinephrine is adrenaline that's released outside the brain. But adrenaline, norepinephrine, and epinephrine are all the same thing. Adrenaline typically is released from the adrenals, sit down above your kidneys. Norepinephrine, epinephrine are usually released from other tissues within the nervous system. But where they're released dictates which one they're called. So if you hear me, I'm talking norepinephrine, epinephrine, I'm using them interchangeably, but just understand norepinephrine. So we have to have some frustration to give us that epinephrine release, to give us that norepinephrine release. Because that error is what's going to initiate the chemical release of modulators within the nervous system that both begins the process of neuroplasticity, but then also completes the process of neuroplasticity. So step 1 is we have to make errors. We have to find something that is a challenge when we're introducing exercises, when we're introducing drills to the individual. We have to then do that in a manner in which they feel a little frustrated. They have to be engaged. How many times have you seen somebody going through didn't I ask you guys to pay attention to this on Tuesday? Over the next couple of days, pay attention to how many times you saw an athlete you were working with, a patient you were working with, how many times you saw them got frustrated? Is that what I had you guys do? How often did you see that happen? The caffeine's kicking in. I pay attention to what we talked about on Tuesday. I just didn't remember all of it. How many times did you see athletes, patients getting frustrated from Tuesday to now? Not much. So then the neuroplastic change never started. We didn't initiate the neuromodulator release within the nervous system to create actual neuroplastic change. So whatever those exercises were, especially, and why is this important, Brandon? Great question. How many times we try to fix movement? The question asked about the school kid of middle school boy back. How many times we try to fix a deadlift? How many times in athletic training, this is one of our favorite things ever, gait training. If we're not getting frustration, we're not getting that release of norepinephrine. If we're not getting the release of norepinephrine, we're not creating any neural changes. We're doing exercise. As soon as that happens, we are not leveraging the nervous system. All we're relying on is physiological adaptation. And that thing that you're doing, best case scenario, the change will happen 6 weeks from today. So when you wonder why, and when you ask the question why, well, I've been working with this, and I hear this all the time, and I have a filter now, so the words going through my head don't come out my mouth. Man, we've been doing all this stuff with the patient, and we increase their dorsiflexion, or we increase their elbow extension, or we increase their whatever, and we get that better, and they leave, and their range of motion is better. But then every time they come back, we're right back to where we started. Guess the words that I want to say. You didn't do the right things. We're relying on physiologic adaptations. That will happen, but understand, when we rely, physiology is 100% predictable. It's always going to respond the exact same way. It's just going to take 4 to 6 weeks for it to happen. So the thing we do today, if we're increasing that shoulder external rotation and we make that better, we made them better. We make change. But we're not going to have that person come in and be like, hey, look at my external rotation. They're not going to be able to do that until fast forward 6 weeks. And we want the results today. So how do we do that? We start to leverage, we're doing the right things from a physiologic adaptation standpoint. We now need to leverage the nervous system so that we can get those immediate changes, especially if we're talking about anything movement related. If we're talking about any range of motion, if we're talking about any movement, we have to access the nervous system to see the immediate changes. And to do that, we have to start with them feeling that frustration. That norepinephrine release is what starts and initiates the process. It's the trigger that starts neuroplasticity. If we don't get the trigger, we don't start the process. And we're completely relying on physiologic adaptations. Now, once you get frustrated, once we release that norepinephrine, the next neuromodulator that's released is acetylcholine. What acetylcholine does, so epinephrine is the trigger. So if you have to remember this stuff, or you want to make sure you remember this stuff correctly, remember epinephrine, norepinephrine, adrenaline, whatever you want to call it, that's the trigger. That's what starts the process. Acetylcholine is the highlighter. So we get frustrated, we release the epinephrine, norepinephrine. The next thing that gets released, if we make the right decision, I'll talk about what that right decision is on the next slide. If we make the right decision, then acetylcholine is released. Acetylcholine highlights the next few things that happen. And that's important. Why do you guys highlight your notes? To remember, when do you want to remember? When does highlighting notes become really important? When's the most important time when highlighting your notes becomes very important? Right before the test, because you're going to go through your notes. Are you going to read every single thing that you wrote? Probably not. But what you're going to do is you're going to skim through your notes. Oh, I highlighted that. That must have been important when Brandon said it. And then you look at it and you're like, oh, that's why he said it. That's why it was important. And it starts to come back to you. What happens if you don't highlight that, though? As you're flipping through, you just go right on by it. That's what acetylcholine is. It's the highlighter. It highlights the thing that happens next. And when I say it highlights the thing that happens next, when we make that error, either we get, well, or we'll talk about the next two options. Option one is you quit. This thing was frustrating. This didn't go the way I wanted it to. I got that little level of frustration. I quit. Guess what that acetylcholine just highlighted? Nothing, because you quit. So option one is you quit. You get frustrated. I don't want to do this anymore. Callan and I in the backyard, he's shooting his free throws. He gets mad. He gets frustrated. He kicks the basketball. And he walks out. He quit. Now, usually what happens, he'll do that 2 or 3 times, and eventually he'll come back and he'll do whatever he was trying to do before. But if you look in our backyard, I can tell how Callan's day has been going by how many basketballs are on the far edge of our backyard. We probably have more basketballs than most high schools in Springfield do. And most of them are usually spread out in our backyard because he'll get mad and he'll kick them. And then he takes after his mom and he's lazy and he doesn't want to go get them. So he just goes and grabs a different basketball because we have several basketballs. And he'll go pick them all up after he's got frustrated enough that he's kicked them all into the backyard. So I can tell how Callan's afternoon and day's been going when I look out and can count how many basketballs are in our backyard. But option one is if you quit. You get frustrated, we just stop. The highlighter that you pull your highlighter out, you highlight nothing because there's nothing there. The other option is you lean into it and you focus. This was tough. The outcome wasn't exactly what I wanted. I need to pay attention. I need to focus on this. And as soon as you start to do that, now you started to highlight. You started to highlight the things that happen next. Because you have to have that direct focus. Especially if you're trying to make changes to the nervous system if you're over the age of 25. Why about the age of 25 do you think is important? Yeah. The age, depending, not by the age of 25, your nervous system is fully matured. It varies for people, but full nervous system maturation happens around the age of 25. If you're over the age of 25 and you're trying to learn a new skill, you've never played cornhole and you want to play cornhole, you've got to get frustrated if you want to get better. You can't just go out there and do the repetitions and expect to get better. Practice, we've all heard the saying, practice makes perfect, right? That's not correct. Practice makes permanent. So whatever you practice becomes permanent. So if I'm just out here and I'm just throwing, what are these? Is there a special name for the cornhole? The bags. If I'm just throwing the cornhole bags and this is all easy and I'm not getting frustrated, then what I'm doing becomes permanent. That becomes a thing that I do. But if I'm wanting to get better at cornhole, and every time I throw, okay, I missed it to the left, and I'm really starting to focus and pay attention, my skill is going to improve because I'm leveraging top-down process. I'm leveraging accessing the nervous system from a top-down approach. If I'm not getting frustrated, then that's not a skill that's going to get better. That's just something that I'm doing. So if you want to get better at a skill, we have to get to that level of frustration. And then we have to make a decision. Am I going to stop or am I going to lean into this? If we lean into it, then we actually have the opportunity to learn. Generally, we don't like to fail at things. And so failing isn't inherently a happy situation. Not too many times that people be like, oh, messed up that one, that was awesome. We don't typically do that. We don't like to fail. And what you do after failure actually makes a huge difference to your nervous system. If you fail at something and you quit, you're not going to get better. If you fail at something and you lean into it and you focus and you accept that frustration, that's where learning happens. That's where skill improvement happens. The brain doesn't recognize failure. What the brain recognizes is the chemical soup that we're creating up there by our actions and by what we do. We feel frustrated, norepinephrine's released. We quit, That's all that's there. We're frustrated. There isn't a step 2. We finish and we're frustrated. If we get frustrated, we decide, no, we're not going to quit. We're going to lean into it. Then what ends up happening is acetylcholine gets released. Acetylcholine gets released. It starts to highlight what happens next. And then we have some things that we need to really capitalize on to leverage the next few repetitions, the next few things that we do. So that what that acetylcholine is highlighting is actually something that when we go back and review it, we can move forward from. So we decided we're not going to quit. When I went to, remember my freshman year of high school, we went to basketball camp, and at basketball camp, they gave us a shirt that I didn't realize it at the time, but it was all about neuroplasticity. The shirt said, on the front it said, winners never quit, and on the back it said, quitters never win. Might have been backwards, quitters never win, winners never quit, whatever it is. I, at the time, thought it was like, oh, that's just a cool basketball saying, coach always said that. I thought that. What I didn't realize was that coach was, way up there in the whole neuroplasticity thing. Because if you quit, your skills don't get better. Your skills don't get better because you didn't create that chemical cocktail within your nervous system to actually improve your skills. If you want to get better and you want to improve your skills, you actually have to lean into those hard things. You have to lean into that frustration. When you do that, the first time you throw the cornhole bag and it actually goes in the hole and it feels good, that's that dopamine release. But we have to understand when it talks about dopamine, that release of dopamine isn't released because we were successful. It's not a reward. And this is why dopamine is this is why if we leverage dopamine correctly, it can be so powerful. But on the other side, if we don't leverage it correctly, it can be so powerful from a negative standpoint. Because dopamine isn't about the reward that you just got. Throw the cornhole bag, it goes in the hole. Oh, success. Dopamine. We tie dopamine with success. That's not the case. Because now you throw that cornhole bag and it goes in the hole. What are you trying to do the next time? You want to get that same thing. Dopamine is released as the anticipation of a reward. So the cornhole bag just went in the hole. I made it. I want to feel that again. So when we chase a dopamine release, we're chasing the next dopamine release. First time that happens, it's a huge bolus of dopamine to our nervous system. First time you shoot a free throw and you make the free throw. I made the free throw. I want to make the free throw again. You're chasing that next thing. You're chasing that next bit of success. That's also why, from an addiction standpoint, dopamine is so powerful because you're chasing that next high. You're chasing that next feeling that you're going after. Not the current one, the next one. That's also why, I made my first free throw. That was awesome. To this day, I can describe the first time in a basketball game I dunked a basketball. I can tell you about almost everything that was going on in the gym right before that happened and right after that happened. I couldn't tell you about many of my other ones, but I can tell you about the first one. I can tell you where Charles Clay was standing on the court. He was one of my teammates. I can tell you that Coach Ward was standing up and he had just slammed his clipboard down. He didn't break it. It was early in the game. I can tell you all of this stuff because I had the dunk, got the dopamine release. It's stuck in my head. And guess what happened every time after that? Guess what I tried to do every time after that when I got the ball playing basketball? I didn't want to just score. I didn't just want to make a basket. I wanted to dunk the basketball. And then it went from, I didn't just want to dunk the basketball, I wanted to dunk over somebody. And then it turned into dunking on somebody wasn't enough. I had to dunk on them to the point that I made them feel humiliated. It kept getting harder and harder and harder and harder to get that same dopamine feeling. That's how dopamine works. We're always chasing that next bit of success. The more novel a situation is, and novel means an easy way to think about novel, new. The more novel the situation is, the greater that dopamine release is. Okay, I got to where I could dunk the basketball. No big deal anymore. Not much of a dopamine release. The first time I dunked over somebody, oh, that's a whole new situation. Dopamine release. First time I I throw the cornhole bag into the hole backwards, that's a novel situation. I've never actually done that. Maybe I'll try. We have to have that. Then with our repetition, the more repetitions we have, the more dopamine release we get. So that's why, from an intervention standpoint, we do something, we do that deadlift, and that deadlift was successful. That's wonderful. We do a different deadlift, they're successful at that. That's wonderful. But if we want that neuroplastic change to take place, we have to get the repetitions. We have to get the successful repetition so that we get that dopamine released. So that we chase that next successful repetition. So that we chase that next successful drill. Does that make sense? Now, what happens if we try something? We're going through and we try this deadlift, we're doing this repetition, this intervention, this drill, and we don't do it correctly. We don't get the dopamine release. What happens then? I want to get that dopamine release. I've got to do this right again. So we have to continue. That's where the important repetitions come from. But this is why I asked you guys to pay attention to patients, athletes doing rehab over the last couple of days. Without the frustration, none of that starts. Without the frustration, you're not going to get that dopamine. You're not going to get the dopamine release because you didn't get the acetylcholine release. You didn't get the acetylcholine release because you didn't get the epinephrine release. And you didn't get the epinephrine release because you were never frustrated. Now, after you've done that thing and you've been frustrated, and we adjust and we fine tune and we pay attention and we get it to where now you're doing that correctly, you're getting that dopamine release because I gave you the feedback. Hey, that looked awesome. That was wonderful. You did it correctly. You get that dopamine release. Now you need to get successful repetitions. Depending on which research study, which textbook you read, which author you listen to, which podcast you listen to, they're going to tell you that you need to get between 10 and 100 successful reps after the point of frustration. That's the key. You have to have the point of frustration. What's even better is if you intermittently have that frustration while you're getting those repetitions. I'm shooting the free throws and I make the first one. Awesome, wonderful, I'm doing it correctly. I got the feedback. I shoot my next one. Awesome, wonderful, I got the feedback. I missed my next one. Oh, why did I miss that one? Okay. If you can get that frustration intermixed with the success, then you can continue to leverage that dopamine release. You can continue to re-engage that norepinephrine, that acetylcholine. You can continue to highlight all of these things. When I was younger, my dad was teaching me how to shoot. We got to the point where, and I grew up in the middle of nowhere, like literally there's my house and then there's cornfields. Like literally in the middle of the cornfield. From my house, it was 7 miles to anywhere. And when I say anywhere, like the next place that you got to was just a flashing red light. That was the somewhere. So this was a couple years ago. Didn't have cell phones. We had 3 channels on the TV on a good day. Depending on how many clouds we had, you only had 2. And that was only if you turned the little twisty dial on the TV to actually get them. I had a bike. And that was pretty much it I won't say that was it. Sounds like I lived a horrible life. I did. I had to entertain myself. We had some, when you live 7 miles from somewhere, you don't have a whole lot of neighbors that can, there wasn't the whole gang of boys I grew up with when I was really young, when I was older, because there was nobody else around. So I grew up doing things to entertain myself, and I growing up in the country, hunting's a big part of what we did. And so my dad started to teach me how to shoot. And early on, once we kind of got going and I kind of figured it out and I decided I wanted to get better, I had a BB gun. That's what he made me learn on. And he got to where every time I would take a shot, it was call your misses. Take a shot, high left. Take a shot, high right. Take a shot, bullseye. Got to where you were calling your misses. Why is that important? Pattern recognition. Because when we're trying to figure out if something's successful, if we're trying to figure out how to complete this task, we need to have pattern recognition, that feedback. So when it comes to us with our interventions, we have to provide that feedback. Sometimes it's positive reinforcement. Great job. You're doing that exactly how you need to. Hey, your back looks wonderful. Sometimes it's negative reinforcement. You look like crap. What are you doing? Which one's appropriate? It depends on the person that's standing in front of you. And that's why I said last time, if you're in an environment, college environment or high school environment where you know the personality of your athletes, you have a leg up from the beginning because you know that if I say, hey, great job to this person, and this person doesn't necessarily respond to positive reinforcement, that's not going to be beneficial for them. But at the same time, if I say, hey, that was horrible, you suck, they'll actually walk away thinking, oh crap, he thinks I'm horrible. If you know their personality, you can pick which kind of feedback you give them. When it comes to leveraging the nervous system, creating these neuroplastic changes, we have to have small focused bouts of learning. Well, Brandon, what does a small focused bout look like? It depends. Because remember, we're dealing with frustration. If we're introducing them to frustration, they're successful for a while, they're getting successful, and the frustration is not too bad, wonderful. As soon as that frustration goes from, I'm a little irritated, to now I'm starting to get mad because I can't complete this, we need to pause and we need to shift gears and we need to do something else. Because we have to leverage frustration and irritation, not them getting mad. Because as soon as they get mad, guess what that acetylcholine is highlighting? A negative outcome with this. They're associating that negative emotion with what we're doing.
So when I think of frustration, I think of like that negative emotions. That's not what you're saying. You're saying that it's challenging.
It's a check.
Focus on doing it.
Yes.
They're like mad, pissed off, never come back.
Great. Can you come up here real quick? You just asked. I'll just give you an example.
That's clarifying.
We're highlighting right now. We're highlighting. Can you just stand on one leg? Not too bad.
Yeah.
Pretty simple. Okay. Just stand on one leg. Just stand on one leg. No matter what, just stand on one leg. And just stand. I mean, we can do this. Is she successful at all? Now, the only reason she's not falling over is because I'm holding on. Is that frustrating? You get mad?
No, I get mad.
If
It's
you
hard.
had to get good at this,
Yeah.
that's a lot different than we stand on one leg. If I just make just a little bit, I make it a little frustrating for her. But this is doable. Once I see it go from I'm frustrated to now I'm getting mad, that's what we're going after. We have to, and a guy I worked with out of Oklahoma, we'll call him Jeff because that was his name. He called it the razor's edge. You want to find the razor's edge of whatever that drill is. It has to be frustrating enough to get their attention, but not so frustrating that they get mad about it. Because when they get mad, then they don't want to come back to rehab because what they highlighted, what that acetylcholine highlighted was anger. And that's now associated with what we just did. Frustration leads to learning. Anger leads to avoidance with this. So again, that's where knowing your athlete, knowing your patient, you can get much closer to that edge when you have that relationship. It's much harder in an actual walk-in clinical situation because you don't have that relationship right away. You can't get as close to that razor's edge, so you're not going to be as successful with that right away. You have to develop that relationship. Now, once Once you have, once you've introduced some level of frustration, you have to give them something to focus on. What do we have them focus on? It doesn't matter. They need something to focus. You have to direct their focus. It's a lot like a magic act. Watch this hand, the magic's happening over here. I'm distracting you, I'm stealing your focus over here while this is where the magic trick's happening. Again, I'm one sidekick away from having a Branson show. We have to find that thing to focus their attention, to focus that frustration on. It doesn't matter what it is. It just needs to be one thing, and it needs to be consistent. And when I say consistent, today it might be keep your heels down on the ground. So I'll use Callan as an example. Dad, watch my jump shot. What's it look like? Your heels are coming up early. I'll be honest, 90% of the time, his heels aren't coming up early. But he's frustrated. I know he's going to continue to take some shots. I want him to pay attention to something. What's he paying attention to? The next 15 jump shots he's taking? The timing of his heels when they're coming off the ground. He's focusing on one thing. That is something that historically with him when he takes his jump shots, if you guys want to know, he would do this. In basketball, this isn't a problem, but let's just think of it as an athletic trainer. Look at my base of support here. I want to jump this way for my jump shot. My base of support. If I have the ball here, and I'm coming up for my jump shot, look at the size of my base of support, how much force I can put in, the area in which I can put force into the ground, okay? If I catch the ball and I immediately come to here, what happens to my base of support? It's about a quarter of what it was. What happens when you make your base of support smaller? Wigglier. If I'm wigglier, what's going to happen to my vertical jump? It's going to be a lot less because now if I have 100% of my muscular effort that I can generate into creating force off of a stable platform, and I've taken 75% of that stable platform and made it go away, now only, this might not be exactly correct, but now only 25% of my potential force can be generated into me getting off the ground. I'm not going to jump aside because I have to use some of that force to keep me from falling over. So, yeah, Callan's heels are coming off a little early. Now he's focusing on keeping his heels on the ground. Whether he is or not, I just need him to focus on something. Next couple days later, we'll go out. How do my heels look? Oh, Callan, your heels look wonderful. Again, I don't really care what they look like at this point. What do I need to pay attention to? Man, your offhand, it looks like your offhand is flipping your thumb just a little bit. Guess what he focuses on the rest of the time he's in the backyard shooting? Keeping that offhand still so that he's not flipping the ball and creating that rotation. Do I ever say, yeah, your heels are popping up, you're flipping your thumb, your head's way forward, and your back's rounded? Do I ever say that? No. Think about this. How often in a rehab setting do you see a clinician, or have you been the clinician that when somebody does that deadlift, yeah, your knees are collapsing, your arch is collapsing, your hips aren't flexing up, your back's rounded, and your head's in a complete wrong spot. You did absolutely nothing correct. What can they focus on with that? Nothing. You have just inundated them with so many things they can't focus. What you just did, that frustration that they had, instead of harnessing that frustration, you've now taken that frustration and you've taken a step closer to anger. Now, all of that might be going on. And let's be honest, a lot of times all of that is going on and they did nothing right. We know that. We need to pick one thing. Hey, what's the one thing, Brandon? I don't care. Pick the one thing. It's going to be very contextual. Some people are going to think, okay, well, if we have all this, if this is what their deadlift looked like, do I start at the feet or do I start at the head? Some people are going to say we start at the feet because that's where the interaction with the ground is. Wonderful, you're right. Some people are going to say, well, we have to start with the head. We have to get the head in a good position, and we have to get the trunk in a good position because everything from the nervous system functions off of this. Yeah, you're right. You can't prove either one wrong. It just depends what your philosophy is. Pick one. Pick one thing. And here's the beauty. If their deadlift or their half kneeling looks like an absolute train wreck, you have a lot of things that you can pick. Today, I just don't want you to let that knee collapse in. That's where we're getting our foothold today. That's the only thing. Next time, it's going to be, I need you to keep your head neutral. Next time, I need you to get rid of that middle school boy band. But we can't throw everything at them all at once because that will take them from frustration to anger. And let's be honest. If I told you guys right now, you guys don't know anything about neuroplasticity, I bet you don't know what the amygdala is. Do you know where things cross over within the nervous system from the right side of the body to the left side of the brain? Can you tell me the structure that is? You don't know what the postures are. You don't know what the patterns are. You don't know what the shapes are. You guys don't even know what I'm talking about when the shapes. I can make you guys feel really bad about how much you don't know. Does that help? No. That's what our patients are experiencing every day when they come to us with a movement issue. We can find all kinds of things. Pick one. That's what we're working on today. Which one? I don't care. Pick one. Usually what I try to do, my approach, because if I say pick one and it's just free for all, you can pick anything, we do need to understand some things. You can start at the feet and work your way up because that approach is correct. You can start at the head or the trunk and work your way up. That also is correct. You can pick the biggest thing. That is the worst thing. That is correct. But that also might be the hardest thing for you to actually see any kind of improvement with. Or you can pick the smallest thing that's going to be the easiest, the lowest hanging fruit. I usually go after whatever I feel is the lowest hanging fruit. Whatever is the thing that I can get them to be successful with right away. Why? Because I want them to feel that dopamine release. I want to do something. I want them to be successful today so that when they come in next time, we're trying to get that same feeling. We're chasing that dopamine release. From a rehab standpoint, I want to be like that drug dealer. I want to keep them coming back because they're chasing that success. I want to leverage my OCD for good, not for the negatives that I could. So give them something to focus on. Doesn't matter what, give them something to focus on. Step 3. So step 1, create frustration. Create the frustration, release the epinephrine. Step 2 was dopamine. I'm sorry, step 2 is the acetylcholine, which leads to the dopamine. We have to get our repetitions. You might think that we've already started the process of neuroplasticity. We've started the process, but we haven't created any change. The actual neuroplastic change, the actual changes and shifts in our cortex, when the change actually happens, when our nervous system rewires itself and improves, it only happens when we sleep. The sleep is the test. So you get the epinephrine that creates a frustration. You highlight what happens next with the acetylcholine. You get the dopamine release. You get all the frustration, all that going on. That's what the acetylcholine's highlighting. You go to sleep at night. That's the test. That's when your nervous system starts going back and looking at what you just highlighted. Guess what happens if we don't sleep? You never go back and review those highlights. You don't improve, which is why sleep is so important. If somebody's in rehab, if somebody's coming to all my post-op patients, one of the first things I'll talk to them about, you have to find a way to get 8 hours of sleep at night. That is non-negotiable for me. And that might be hard, and that might require making some changes. That's fine. But for the next 8 weeks, I'm not going to give you a home exercise program. I'm not going to ask you to do anything else because I want you to take that 15, 30, 45 minutes of you investing in your home exercise program of exercises. I would rather take that 45 minutes, put it at the end of the day, go to bed 45 minutes early. Because whatever I'm doing in here from a clinical standpoint, if they're not getting 8 hours of sleep, what they highlighted, they're throwing that notebook away because they don't have the opportunity to go back and review it the next day. It would be just like you guys. The end of last semester, you threw your notes away. You couldn't go back and review them this semester. That might be important to do, right? What would happen? How awesome would this be? You guys take notes, you highlight, you do all that wonderful stuff. And then I stand here at the door, all right, give me your notes, I'm taking them, throw them away, shred them. That would be frustrating, right? That's the same thing that happens if you don't sleep. It's just they don't comprehend that that's what's happening. We have to have sleep, non-negotiable. Short term, for the next 6 weeks after a surgery, we have got to find ways to get you 8 hours of sleep a night. Easier said than done. I say 8 hours. If they land at 7 hours, I'm happy. But I don't say 7 hours. Any idea why I don't say 7 hours? Because then they'll hit 6, and that's not enough. We need 7 hours minimum. I tell them 8. I actually tell them I need 8 to 10 hours of sleep, hoping that they'll at least get the 8, which means we'll actually get 7. Less than 7, there's just not enough. We're not going to get into the whole cycle of sleep, but less than 7, you're not getting enough cycles of deep sleep to actually create the neuroplastic rewiring. There's just physiologically not enough time spent in deep sleep. You got to have at least 7 hours of sleep a night to go through at least 4 or 5 cycles of deep sleep to get enough time for that to happen. It's also the same if we're talking about things from a training standpoint. Somebody's wanting to get stronger. Somebody's trying to put on.
I was going to say, so for the greater than 8 hours of sleep, like when you have patients post-op and they kind of complain about not being able to sleep because of pain, I know we talked about breathing last semester, but is there anything else that you do for that if they just say they can't sleep or they can't stay asleep?
It depends. Am I gonna? It depends on what's causing. Yes. Do I do something? Yes. It depends on if somebody's telling me they can't sleep. Then the next, I don't know what I'm going to do at that point in time. I need another couple questions. First question I'll ask him: when you tell me you can't sleep, are you having trouble falling asleep, or are you falling asleep but you can't stay asleep? You wake up and then have trouble going back to sleep because those are different problems. If somebody's telling me they can't fall asleep, then my next question is, can you not fall asleep because you can't get comfortable? Can you not fall asleep because the pain that you're having? Or can you not fall asleep because your mind is just racing? If they can't get comfortable, all 3 of those have a different response for me. If they tell me they can't get comfortable, then we get in, we have a conversation. Well, how are you sleeping? Do you sleep on your? If somebody tells me they can't get comfortable, I need to know: do you typically sleep on your back? Do you typically sleep on your side? Do you sleep on your stomach? Why is that important? If somebody has a shoulder surgery and they're a side sleeper, you have to find a solution for them. It's not going to be in a bed. They need a chair or recliner, something that they can kind of sit up in. If somebody tells me that they're a belly sleeper and they're wearing a knee brace, we need to find a solution for you. You might need to sleep on the couch. Why a couch or a chair? Because a couch has a back and you can kind of wedge somebody up against that and it keeps them from flipping around. A chair, same thing. Not ideal, but at this point, I'm not looking for ideal. I'm looking for realistic ways to help them get more sleep. So I look for how they sleep and try to give them solutions for better ways to get comfortable. If it's a shoulder or knee, we might have to find ways to prop them up. For the longest time in my career, because elevation's a good thing, right? Especially when somebody has swelling. Lower extremity injury, I tell people, because we need to elevate that leg, you're going to be asleep for 8 hours. When you go to bed at night, you're going to set some pillows on the foot of your bed, and you're going to prop your foot up onto those pillows, because that's going to elevate your leg. Yeah, I elevated the leg, but then they couldn't sleep. So that's a horrible solution. Better solution? Can't say it anymore. I don't have a great solution now. Better solution was take the phone book or find an old textbook, something that's 2 to 3 inches thick, put it between your mattress and the box springs, and that at the foot of the bed, that'll elevate the whole foot of your bed 2 to 3 inches, and that's enough. And that's a whole lot easier than trying to lay with your foot propped up on pillows. So try to find a way to get them comfortable. If they're telling me, and then that's also, I'll recommend that for that, and if it's their mind's racing, if their mind's racing, I have them download, there's a couple different apps I send them to. One of them is called Reverie, Reveri, I believe. R-E-V, yeah, it's Reverie, R-E-V-E-R-I. It's a purplish pink icon with a white circle in the middle. It's a self-hypnosis app. When I say self-hypnosis, it basically just walks them through settling their mind. It gives them it's a way of directing their focus. And I'll help them get that set up. There's a paid version of it. There's a free version of it. There's some other apps out there. The Calm app is one of them. They have a paid version and a free version. Something to get their mind to focus on so that they're not living inside their head. I'll give them that to focus on. And then on top of that, we'll get into our nasal breathing. We'll get into, I just want you box breathing in and out through your. If it's because they're in pain, then one of the benefits of post-op patients is post-op patients have access to some things that we don't typically run into in our non-post-op patients. You guys know what that is? The good drugs. The hydrocodone, the oxytocin, all of that stuff. That'll be the only time I recommend is take that before bed. Try to not use it as much. Let's get away from all of it as much as we can, but if you're really struggling to sleep because of the pain right before bed, that would be the time I would tell you to take your pain meds. Some people, however, I just don't want to take pain meds for whatever reason. I'm not going to force that person to take pain meds. Then what I would try to do is leverage like a 10 unit or something to where I put that on and we have that on right before they go to bed. Just again, to try and turn down the input of pain enough to help them get to sleep. And I would also have them leverage the breathing and all that goes along with it as well. If it's they wake up and they're able to fall asleep, but then they can't get back, they continually wake up, then I'm going to go back to and tell them, okay, you wake up in the middle of the night, why can't you get back to sleep? And we go right back to this exact same conversation. And a lot of times, every time for me anyway, if I wake up in the middle of the night and I can't go back to sleep, it's because my mind's racing. I'm thinking about what all I have to do. And I've just gotten to the point now, if I wake up in the middle of the night, even to let the dog out. I wake up in the middle of the night, I'm grabbing my cell phone. First thing I'm doing is I'm turning on whatever app or whatever book on tape I have. I have some really boring books on tape, not because I like listening to them, but because when I sleep, I put on this boring book on tape and I set it there and I listen to that so that I'm not thinking about the 112 things I have to do. Help them fall back to sleep. So I'll leverage whatever answer that first one was. That makes sense, kind of? Honestly, there have been patients I've seen where we spent 30 minutes of our hour having that conversation, and I'm perfectly fine having that 30-minute conversation. That's how important it is to get them to sleep. And I will go out. If you're telling me that your shoulder hurts when you're sitting in class, or you're telling me that, walking on crutches, it's really starting to rub my shoulders. Listen, tough enough. I'm not going to be super sympathetic to that. You're going to have to find a way. I don't know what the answer is. You're going to have to find a solution for that. I'm not going to be a jerk about it. I'll spend a little bit of time. Here's a couple things you can do. I'll try to throw you a bone here or there. But as soon as you tell me that we can't sleep, everything else stops. And we're having this conversation. That's how important sleep is. Because if we don't have sleep, I just wasted all of my time. And I don't like wasting time. So when it comes to neuroplastic changes, like I said earlier, the brain doesn't recognize failure or success. It recognizes the chemical mix-up of what's going on inside our head. For neuroplastic change to actually happen, for us to rewire the brain, for us to shift the cortex, there has to be epinephrine, there has to be acetylcholine, and there has to be dopamine. I don't remember why I put the picture of the snail up there. That's been bugging me all morning. I had a reason for it, but I don't know what it was. I don't know, so don't ask. We have to have those three. They have to be released in the right order at the right time. Because there's a lot of things that will release epinephrine. If a clown walks through the outer doors, I'm going to have a dose of epinephrine released. Because I don't like clowns. If I go out to my truck and I find that peanut M&M that I dropped yesterday when I was driving home, I'm like, ooh, peanut M&M. Oh. It's my truck. It's just been sitting on the floorboard for less than a day. It's got the candy coated covering to keep it fresh. I'm gonna have a dopamine release because now I'm looking for M&Ms in my truck. During the day, you'll have epinephrine releases. You'll have acetylcholine releases. You'll have dopamine releases. That doesn't mean neuroplastic change is happening. It only happens when those two are released at the right times, in the right sequences, in the right dosage, tied to the thing that we're trying to do. When all of that happens, we can get neuroplastic change. If it doesn't, we don't get it. So from a rehab standpoint, the absolute first question that you have to be able to answer, regardless of what that person is standing in front of you for, regardless of what the injury is, who the person is, how far out they are, everything that's going on, you have to answer the question, what adaptation do you want to create for that person? You have to know what you're trying to do, and you have to be very specific with that. Once you know the adaptation that you want to create, you have to find the drill, the intervention, the exercise, the thing that's going to magnify that. So if somebody can't get into if I'm wanting to fix somebody's deadlift, their deadlift looks horrible. Guess what? One of the first places I'm going to put that person in, well, guess what one of the first places I'm going to put that person into is? Where's my starting point going to be? Do you think I'm just going to have them deadlift? No. Where do you think the easiest place to have them start is going to be? A little bit further up than quadruped. I'm not going to jump all the way to quadruped right away. I might eventually get there. If I'm watching that 10-year-old with a middle school boy back try to deadlift, and it just looks like an absolute train wreck, where do you think my starting point with him is going to be? Before standing. I nailed standing. You guys remember this one? Set up for bottom of deadlift. We're going to get into this position, and I'm just going to, hey, hang out here. I just want you to breathe. Because here, if his knees are collapsing, do you think I can say, hey, push those knees out a little bit? We can't. If he's got that middle school boy back going on, do you think I can say, hey, flatten your back out a little bit, or whatever cue I need to, and then take 5 breaths? I can't. Now, if that works, wonderful. I'm then going to find ways to magnify that. So if his knees are doing this, and he can get here, and I say, hey, can you push your knees out? And he's able to push his knees out, and that's pretty simple. And he can hang out here, and it's not that big of a deal. Do you think that's very serious for him? Is he getting frustrated with this? No. What's something I can do to magnify that even more? I can take a band. Where would I put the band, though? Do I want the band to pull my knee in this way? Do I want the band to pull my knee out this way? You want to magnify the problem. So this is what I don't want to happen. He can get here and he can maintain this. If I pull the band out this way and I assist him, it's making it easy. But if I magnify the problem and he's having to push out, now we can get into that level of frustration a little bit. Or I can take my hand and I can physically push that in and he's having to push out against me. Either one is correct. We want to magnify the problem. So we want to find the drill that magnifies the experience we're trying to correct. We have to give them the frustration. We have to let them be successful. We have to give them. We have to expose the patient then to everything we're doing. The best advice I can give you, shut your trap. Shut up. Be quiet. Because how many times have you been the person or you watched the person that when they're correcting an exercise, oh, great job, keep that knee out, push out, push it. They never shut up. We think we're being helpful with that. We don't do it because we want to be annoying. We do it because we think we're helping. But remember, just like we talked about on Tuesday, the language of the nervous system isn't visual. That's why mirrors don't work. The language of the nervous system isn't auditory. Because by the time I tell that person, So if I'm doing a deadlift and my knees are collapsing, by the time you guys say, hey, Brandon, push your knees out. Hey, Brandon, push your knees out. Well, I've already finished the rep. And now I'm thinking, push my knees out. Okay, the timing's off because I can't get the input, process the input, associate it with what I'm doing, create an output in the time that the movements happen. So when we're talking, we're just literally blowing hot air out. It's not doing anything. Hey, don't let that knee collapse. Ever. And focus on that. Now, we might have to show them what knee collapse means because, okay, I won't let that happen at all. Because in my mind, you guys see this, right? In my mind, I see the most perfect knees ever. Perception and reality are not the same thing. What's happening in my head isn't what you guys are seeing. It might be an awareness issue. Hey, take your eyes. Oh, hey, that's not what my knees are doing. Well, whose knees are those? Those literally are your knees, and that is what they're doing. Keep them like this. You might have to make them aware. As soon as they're aware, as soon as you've used your words or your touches to make them aware, be quiet. They need to work things out. And your voice, your instructions, is one more thing that they're having to process that's taking them away from the focus of their needs. So, be quiet. Let them get frustrated, but don't let them get mad. Take them to the razor's edge. Stop them before they get mad. Give them breaks. Remember, neuroplasticity, short focus bouts. Short focus bouts, you have to pay attention. This is one of the reasons why I don't like it when you have clinicians that say, okay, you're going to do 3 sets of 10. She's either going to be very mad when I come back because she couldn't do it, or she's going to be like, yeah, that was a piece of cake. I don't know what happened. I don't know how close she was to that razor's edge. Now, I might say, hey, I need you to do 10. Remember, don't confuse me not standing next to her to me not liking her, not paying attention. I might be here. She's doing the 3 sets of 10. I'm watching what's going on here. I'm paying attention to what's going on there. Hey, go ahead and set it down after that. That was only 5. I don't care. Set it down after that. Or gets to 10. I need 3 more. I don't have to be right there, but I still have to see what's going on and pay attention to what's going on because I need them to get enough actual successful reps. And sometimes when I say do 10, they might only need to do 2 or 3. I need to be able to stop them at 2 or 3. I might say do 10, 10 wasn't enough. They need 5 or 6 more. And I'll say keep going. And usually what will happen in this situation, it'll be, hey, keep going. How many more do you want me to do? I'll tell you when I'm done. I phrase it like that. I'll tell you when I'm done. To get a little chuckle out of them. You guys are supposed to laugh. I'll tell you when you're done. And then, okay, we're good, set it down. Because I need them to get to the point that it's serious. And just saying arbitrarily do that 8 times, we can't control that. Give them one thing to focus on. Give them reps and feedback. I won't tell somebody how they're doing until we're done. So you did your 10. I'm not going to be saying every time, that one was good, that one was bad, that one was horrible, keep your back. I'm not doing that. That goes back to number 1, be quiet. We get to the end, hey, those looked a whole lot better. I noticed as we got to the end, that knee was starting to collapse a little bit more. So when you get to the 3rd or 4th one, really, the only thing I want you thinking about is that knee being over your patella. And I'll also throw out weird anatomical terms. They won't know, but I'll laugh on the inside. I need you to really pay attention to this one. Okay, got it? Good. And then we'll come over and we'll be done. Oh, no, you need to stop right now. And then come back. Hey, I stopped you because we got to that 4th one and it looked wonderful, but then on the 5th one, you just couldn't do it. On the 6th one, there was no saving it, so we just needed to stop right there. Next time, we're going to do the exact same thing. Or it might be, hey, wonderful, you did a great job. Next time, what I want you to pay attention on is your left earlobe. Because it was doing some weird floppy things that time. I need you to pick something. Doesn't have to, but I'm not going to do that in the middle. It's always going to be in between sets. Most important thing that we can do, as soon as we're done, we're finished with this rehab session, 10 diaphragmatic breaths, 5 minutes of diaphragmatic breathing, whatever is appropriate. But we have to take a moment where they get that diaphragmatic breathing. Ideally, we're going to take 5 minutes. Hey, great job. We just finished up today. I want you to lay on your belly, cross your hands, forehead on here, breathe in and out through your nose, set your phone, set your watch for 5 minutes. Then in 5 minutes, you can stop. Eyes closed, nasal breathing only. You're not multitasking, you're not texting somebody, you're not checking your calendar, you're not emailing, you're literally just laying there with your eyes closed for 5 minutes. If they can't give me 5 minutes, let's just get 10 breaths and get out the door. It can be laying on their back. It can be like, I like laying on their belly here, just because if I'm laying on my belly here, literally the only thing I can see is right here. I don't see all the craziness going on around me. If I'm laying on my back and I'm trying to have my eyes closed, I'm going to see all these just out of the corner of your eyes, even just the changes in light through your eyelids. So I have people lay on their belly. 10 breaths minimum, ideally 5 minutes. And then make sure you're going to sleep at night. Everybody knows the hardest part is, well, I just don't have time to go to bed. No, you just don't have a plan to go to bed. Well, I have to get up so early. Okay, wonderful. There's this thing called math. What time do you have to get up? I have to get up at 5 o'clock. Okay, I need you to get 8 hours of sleep. So let's rewind 8 hours. So midnight's 5 hours. 3 hours before that's 9 o'clock. I need you to go to bed at 9 o'clock. That's really early. I know. You have an ACL surgery. You're telling me you want to do everything to get back. This is what I need you to do. Short term. Guess what? It's not like when I grew up. You missed Airwolf, you didn't get to see Airwolf again. You missed the Dukes of Hazzard, you didn't get to see Bo and Luke again until the end of the season when you hope they replayed the episode. Now, you miss Yellowstone, stream it when you wake up in the morning. You have options. And again, if you're telling me as an athlete, your number one priority right now is to come back from this surgery, the most important thing that you can do is set a bedtime alarm. Not an alarm for when you're going to wake up. That's important too. But at 8:30, you need an alarm that's going off that says get ready for bed. And then whatever strategies we might need to do to help them fall asleep, we're starting that. If somebody's struggling with sleeping, if I'm going to have them do anything, I want you to foam roll your stomach. I want you to lacrosse ball your belly. I want you to do something that 30 minutes before you go to bed. Lacrosse ball, foam roll, whatever. And it can be wherever, because the deep pressure stimulates the parasympathetic nervous system, which, if you guys remember familiar with the parasympathetic nervous system, that begins the process of rest and digest. It takes us out of sympathetic hyperarousal. So if I have them do anything, about 30 minutes before you go to bed, grab that hypervolt, grab the foam roll, grab the lacrosse ball, whatever tissues you need to work on, start doing that about 30 minutes before bed, because that will also help you start to feel a little bit tired. If you really struggle with going to bed and you want to go to bed at 9 o'clock, then I'm going to recommend at between the hours of 6 p.m. and 7 p.m., I want you to take a hot shower for 10 to 15 minutes. Why a hot shower 10 to 15 minutes 2 hours before bed? Because you take a hot shower, it's going to slightly increase your core body temperature. That's why we have to be in there 10 to 15 minutes. It needs to be almost uncomfortably hot. 10 to 15 minutes, it's going to elevate your core temperature just a little bit. But guess what happens after you elevate your core temperature about 2 hours later? There's a rebound effect. It drops. It actually goes below the 98.6. So we actually get cool. Once we get cooler, it's easier for us to fall asleep. And I'll also have a conversation with them about keeping their bedroom as cool as possible as they possibly can. Again, just little things to leverage their nervous system. Deep pressure to stimulate the parasympathetic response, a hot bath, a hot sauna, a hot shower. Heck, if you're in Missouri, just go outside at 7 o'clock, come back into the air conditioning after that, to get an increase in body temperature so that we get the rebound decrease about 2 hours later. Because if you do that, and then you diaphragmatically breathe, it actually makes falling asleep relatively easy. Next time, we're going to talk about what's actually inside your melon, but we won't talk about that one today. All right, that's all I got. Any questions?